So what I'll do now, guys, is I'm going to demonstrate how we're going to suction an intubated patient using the closed suction technique. Okay, we can see we have our patient here, Mr. Jones, on a mechanical ventilator, and we've got our suction system still set up the way we left it. Okay, so to start, I'm going to actually put this suction system on to regulate, set my pressures appropriately, turn this down, include my tubing. Sorry for the wobbly camera work. Regulate my temperature, pressure, maximum of 100 millimeters of mercury. Let that go. And I'm going to come over to the ventilator and show you a few different things. First off, we know that it's important to hyperoxygenate these patients or pre-oxygenate these patients. You can do that a number of different ways on these ventilators. First, you can actually dial in 100% oxygen, accept, pre-oxygenating your patient. That way, you have to always remember the next step is to turn it back down at the end. So, there's a button on this ventilator, on the PB840 here, it says 100% oxygen cal. You press it, lights up, and on the bottom of the screen it says you get 2 minutes of 100% oxygen. Generally what I'll do is I'll hit that button, and I can hit this 2-minute silence button as well. Because you can understand that when you actually do suction your patient, you are going to get some increased peak pressures because of the resistance of the catheter, the resistance of the airway when you introduce a catheter. So that's pre-oxygenating my patient and giving me some much needed silence for this procedure. So we need to assess our patient. So Mr. Jones, I'm just going to have a quick listen to your breathing, if that's okay. Okay, I'm just going to put my stethoscope on your chest here. I'll pull your gown down. I'll give you your covers back when I'm all done. Assessing an intubated patient is a little different. I can't get this guy to sit up and do a proper auscultation of every different lobe and every different area. It'd be great to, but just with the constraints of the ventilator and the sickness of your patient, it's probably not likely. So you're going to have to do a very good job of auscultating the anterior chest, way down in there to get those lower lobes, and find out as much information as you possibly can to see if this is a needed treatment for suctioning Mr. Jones. Okay. Some of the other ways that you'll be able to tell if Mr. Jones is going to need a suction is by actually looking at your ventilator. If he was on a volume controlled breath just like he is here, we know that my peak pressures are variable. So if I start seeing a big rise in peak pressures from previous with these same settings, I might know, that might tell me that there's something going on in his chest for me to investigate. If he was on a pressure controlled breath, then we know our volumes are dynamic. So I'd start looking at my exhaled tidal volume and seeing if that's dropping, and knowing that, again, something's gone on in my patient's chest, I need to further investigate. Okay. Waveforms are another great place to look for when investigating your patient for suction needs. And these flow waveforms, you'll start seeing artifact if there was anything rattling around in the airways, and that can tell you right off just by looking at it, almost from the end of the bed, there's something going on in the circuit or in the system or in your patient, and that should draw your attention to identifying it. Okay. The next thing you want to do is actually attach your suction tubing to the catheter. So, attaching the suction tubing to my closed system. Okay. Put my patient on 100% oxygen, and I'm going to explain this procedure to him. Mr. Jones, it's Dave again from Respiratory Therapy. What I want to do here, sir, is just give you a bit of a suction. When I listened to your breathing, I heard some stuff in your chest that I think it needs to come out. So, unfortunately, with that tube in your throat, you're unable to cough and clear a lot of those secretions on your own. This procedure will just help with doing so. It's a small catheter that I'm going to feed down that breathing tube in your throat. It's going to make you cough. Unfortunately, it's a little uncomfortable. It won't last long, though. And I'll apply a little bit of negative pressure, some suction, and see if we can get rid of those secretions that are in your chest. Okay? Bear with me. I'll be here the entire time. If anything comes up, please just let me know. Raise your hand. Tell me something's going on, and we'll address it. Okay? So I'm going to don my PPE. Ensure my ventilator is 100% oxygenating, and I've got my alarm silenced. Now these closed systems are great. I don't have to breach the system for this. So what these systems allow us to do is they have a catheter inside this sheath. There's always a thumb port on these catheters that are going to allow you to actually depress and occlude for negative pressure. And that's what's actually going to give you the suction when you depress that thumb port. Mr. Jones, you're going to expect a big cough here. So you're going to advance the catheter all the way down until you feel resistance. So I feel resistance there, should stimulate a cough. Big cough, Mr. Jones. Press down on the thumb port and rotate as you come out. Big, big cough. Good, good, good. All the way out. Excellent. There's a little line on this that's marking the indication, so you don't want to pull that all the way back, or obviously the sheath will start to take some of the volume from the ventilator. It's just a little O-ring in there that seals this, this catheter. So we've got our catheter all the way back out of the tubing, and at this point I want to assess my patient to identify if there's a need for more suctioning. You did great there, Mr. Jones. As you could see, when I was pulling that catheter back, I rotated it slightly. The idea of that is just to prevent the catheter from actually adhering to one of the walls. So if you're pushing it from one side of the trachea to the other, you might get more secretions up, as well as you might prevent it from actually adhering or sticking or sucking to the tracheal wall itself. Okay. All right, Mr. Jones, everything looks great here. I think we got all the secretions out of your chest. I'm just going to verify and assess you again, and I'll be back, okay? At this point, you want to make sure ventilation is appropriate, looking at everything to make sure that it hasn't changed or everything's still the same, and resume your current settings. So take your 100% oxygen off, take your alarm silence off, and assure your alarms are where they should be.